I need different glasses to be able to see long distance.
We do minus reading, which has never been an issue.
Chairman Lee, members of the committee, my name is Carl Young. I'm a parent and advocate for individuals with mental illness and their families. Today I speak on behalf of the Mental Health Advocacy Network. MHAN advocates for consumer and family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. MHAN has provided testimony since the 64th Interim Human Service Committee meetings, the 2015-2016 session, regarding our priorities for mental health services. We argue that peer-to-peer and parent-to-parent support, consumer choice, diversion from corrections, a core services zero reject model, and conflict-free grievance and appeals processes, and the access to a full and functional continuum of care that serves as the backbone to correcting the crisis in North Dakota's behavioral health system. MHAN supports the recently released HSRI, that's the Human Services Resource Institute, North Dakota Behavioral Health System Study, and its recommendations. Just as was recommended by HSRI, MHAN supports the creation of an action plan for implementation with implementation goals that are measurable. The HSRI report recommended the following. 1.1, reconvene system stakeholders, including service users and their families. 1.2, form an oversight steering committee to coordinate with key stakeholder groups. 1.3 is establish work groups to address common themes identified in the report. MHAN recommends that the steering committee and any resulting work groups have a 51% consumer and family membership. HSRI recommends that the state of North Dakota strengthen advocacy throughout the state, particularly among individuals with lived experience and their families. And that's a quote from the report. The reason for this is that a strong and diverse advocacy community composed of individuals with personal lived experience of behavioral health systems and their family members is an asset to the system. Further, advocacy communities can partner with government and provider organizations to collaborate on systems change initiatives, and they can hold organizations accountable to ideals of recovery and person-centeredness. MHAN is aware that there may be a debate about which entity is responsible for requiring the creation of such a steering committee and work groups. In the past, directives from either the North Dakota Legislature or Department of Human Services to create the steering committees and task forces have been met with bureaucratic lethargy. Without legislative direction, the Department of Human Services has been slow to respond to consumer and family involvement. But even with legislative direction, consumers and families notice that government entities seem unwilling to respond with the urgency that a crisis would ordinarily demand. As an example, the Children's Behavioral Health Task Force was delayed by several months and finally held their first meeting in May of this year. The HSRI report also noted a similar phenomenon, stating, when asked about the quality and type of interdepartmental collaboration, a common stakeholder response was that they have a lot of meetings together, but that translating talk to action once the meeting adjourns is the challenge. As such, MHAN has no inherent jurisdictional preference with the steering committee and work groups. MHAN has a few simple requests: that the state of North Dakota respond in a timely manner throughout the planning and implementation process, creating a measurable action plan with the 51% consumer and family membership on the steering committee and resulting work groups, and that the state of North Dakota actually implement the action plan. MHAN's #1 priority is funding for peer-to-peer and parent-to-parent support. Peer support is an evidence-based practice. The Shelter Report of 2014 made clear the use of peers, family support peers, recovery coaches, and other persons with lived experience is an evidence-based practice. A growing national trend with good treatment outcomes. In rural areas with behavioral health professional shortages like North Dakota, using peers and other interested persons like teachers, law enforcement personnel, emergency workers, etc., are instrumental to expanding the workforce. In addition, increasing the number of outstation workers in the community is key to improving access to services. The HSRI report also recommends the expansion of peer support services. In recommendation 7.8, the state has recommended to support a robust peer workforce through training, professional development, and competitive wages. MHAM believes in a full continuum of care, which includes prevention and federal, state, and local programs that provide services to mothers who use drugs or alcohol and to newborns who have NAS, which is neonatal abstinence syndrome, and evaluate those programs and services to determine if gaps in the programs or ineffective policies exist. MHAM concurs with the HSRI report when it says that the state of North Dakota needs to expand outpatient and community-based service array. The report mentions community-based service needs include flexible supports such as peer support and community health workers. The report recommends DHS ensure that peer services are supported through these national practice standards to ensure fidelity to peer support values and to develop career opportunities and skills for peers working in behavioral health. If the citizens of North Dakota are not receiving mental health treatment in the community, there are a few other choices. The HSRI report states that the criminal justice system has been functioning as a default behavioral health provider for many people in North Dakota. And stakeholders rightly saw this dynamic as troubling, highly troubling. As had been previously reported by the Department of Human Services, less than 10% of the adult SMI population, seriously or severely mentally ill population, has been served in the community by human service centers. Meanwhile, 70% of North Dakota judges had reported that they sentenced individuals so that they could receive behavioral health treatment. While MHAM stresses that services must be provided to individuals before they enter the criminal justice system, we are encouraged by the attention to reducing recidivism as received. It is estimated that under 4% of the youth with severe emotional disturbances population are receiving community-based services at the Human Service Center. Just like in the adult system, if children and youth are not receiving mental health treatment, the options are limited. MHAM has become alarmed at the dramatic increase of youth with severe emotional disturbances in the juvenile corrections system. In 2011, 49% of all youth in juvenile corrections had an SED. By 2017, that figure jumped to 79%. 79%. North Dakota needs a fully functional mental health system of care for people of all ages. MHAM has long argued that the North Dakota mental health system must provide its citizens choice in mental health services through a voucher system or like model to allow consumers access to services in the private sector. In part, we argue for a voucher system because services are not available equitably in all regions, nor are they adequate for the need. The 2014 Schulte report further argued that the existing monopoly had created less competition and thereby a lower standard of care. The HSRI report noticed that the state has a voucher program for substance use treatment, but lacks a voucher program for mental health services. HSRI also recognizes that the voucher funding stream is a key resource that can be flexibly deployed to meet unique community needs. If the state were to implement this program for mental health and expand it comparably to the HSRI recommended levels for substance use voucher program, HSRI noted that it would help increase access to support services and fill in gaps in the service continuum. MHAM believes that DHS must adopt a zero reject model for service delivery. Currently, the state system of care turns away people because of waiting lists, wait times, non-cooperation, or being too sick or not sick enough. The Schulte report said the current system encourages failure at various treatment levels before authorizing treatment. This is not recovery-focused treatment. Parity for mental health services is not currently happening within the state as mandated by federal law. The HSRI report also noticed a lack of zero reject principles in the state of North Dakota, stating several stakeholders were concerned about attitudinal barriers to working with people with complex needs, describing a culture in which individuals seeking services must prove that they are motivated as a precondition to receiving support. Also, several other stakeholders excuse me, observed a dynamic in which some providers require individuals to prove they are worthy of support services and discharge service users for behaviors that are part of their behavioral health issue. There are many programs within the state of North Dakota mental health system, and one solution will not solve all problems. In many regards, the North Dakota mental health crisis is a crisis of funding. A crisis of funding. Both the Schulte report and the HSRI report inform the reader that the lack of funding is not only from few state dollars apportioned to mental health services, but also as a result of not pursuing federal funding opportunities. That said, there is one funding opportunity that will address a number of the problems identified over the course of the last decade. The state can pursue a 1915 I state plan amendment to its Medicaid plan. As the HSRI report states, the 1915 I offers states the option to include a wide range of home and community-based services as a state plan option, including services that address the social determinants of health. Services identified as lacking in both the Schulte report and the HSRI report could be covered. These are peer-provided services, supported employment, supported housing, etc. DHS has already completed much of the groundwork to making 1915 I a reality for North Dakota. HSRI argues that if the state moves swiftly to implement 1915 I, this crisis can start to end and reduce overall system costs in the long run. North Dakota is running out of time. The Supreme Court decision in Olmsted versus LC of 1999 and subsequent rulings said that states must provide community-based services for individuals with disabilities and those individuals at risk for institutionalization before requiring that they seek treatment in an institutional setting. The HSRI report documented a high proportion, approximately 1 in 4 of individuals under the age of 65 receiving behavioral health related services in long-term care facilities. Schulte warns that lawsuits are happening across the country in which states are not offering a choice of services to individuals or requiring that they seek only institutional care. The need for home and community-based services is critical with changes in the federal landscape and the expectation of integration of individuals with needs into the general population. Louis Bossing of the Vaslon Center for Mental Health Law's multiple presentations to the state legislature during the previous interim sessions, as well as the previous general legislative session, highlighted how 1915 I state plan amendments have been used to. North Dakota has spent most of this decade researching a mental health crisis that has shown no signs of weakening, is only growing in intensity. The good news is that we can report no further study is required. What is required, however, is a political will to get the job done. For the moment, this is still a choice for you to make. I would be happy to take any questions that you may have.
Thank you, Mr. Young. Who has questions?
I have a question.
Okay, and then Representative Lawrence.
The question I have, Madam Chairman, and Mr. Young, is, has your organization penciled out what is required to implement the HSRI recommendations? And I'm wondering if anybody has developed a list. I understand you have formally endorsed those recommendations, and I think many organizations are Has anybody developed a list of the costs associated with those recommendations being carried out? That would be really helpful for us if we kind of put that in our repertoire. So is that something your association has done, or do you know of anybody who's done that?
Senator Mather, Chairman Lee, members of the committee, that is not something our organization has undertaken at this point. I don't know that we have the resources in our small organization to do such a thing, but we could sure talk about it at our next meeting.
Yeah.
I would say that I imagine somebody at the Department of Human Services has evaluated that part of the cost.
And maybe we can ask there too. Thank you.
Any further questions, Representative?
Thank you, Madam Chair. Mr. Young, you mentioned repeatedly in your testimony, talking about peer-to-peer counseling and such. Tell me how you define a peer in a case like this.
Representative Carls, Lee, members of the community. I'll use my family as an example. My son has fetal alcohol spectrum disorder. He's on the spectrum. He has zero impulse control, zero executive function, and really struggles with day-to-day decision making. Other families need a parent like me who understands what they're dealing with to help them begin the process of seeking help for their child. My son, while he can sometimes sound like he has a PhD at the age of 17, really doesn't understand most of what he's saying. But he is still, I'll go back 3 weeks, he was at a summer camp for kids with fetal alcohol spectrum disorder in Chicago. And he got an award for being a mentor to a young man at the age of 10. My son just turned 17. No idea where his leadership came from, but that's peer-to-peer support at its simplest. I don't know if that answers your question.
Madam Chair? But tell me, how do you fund something like that?
Representative Carls, Madam Lee, or Chairman Lee, members of the committee, I wish I had an answer for you. I'd like to say we could tap into the legacy fund. I would like to say that we don't have to go out of state to get services, which cost an exorbitant amount of money and separate families when we can provide that level of support here. I think that if, for example, my son was at a residential facility in Fargo, and it costs, I think, somewhere in the neighborhood of $9,000 a month to keep them there. And I think we could provide peer-to-peer support a lot cheaper than $9,000 a month in the community that he currently lives.
I can assure you that within the Human Services Committee's work and with Ms. Sanchez, she's already done the curriculum and training programs for peer-to-peer. For example, somebody who might suffer from alcoholism would be, in fact, at AA, I was giving examples. I can think of as a simple example of peer support. One of the most successful peer-to-peer things in our Moorhead area is a small entity in Moorhead, which also serves short people. It's all people who are in recovery from substance abuse. So we need more of those. There has been a class put on by the jail chaplains, and there were, I believe, in the last class, 47 people from 6 or 7 different churches who attended in order to be peer support counselors. And it is often better, I think, that the professionals are, in this committee would say, that if somebody who has experienced it, but there are others who with proper training can do a good job. They were talking about some celebrity who was in the hospital today because of a substance abuse overdose, and she had fired her solar coach in the last week. That wouldn't have anything to do with that person. So someone who's been there and done that? Anyway, we're working on it. We're trying to increase the number of people. UND has a curriculum also. We don't need to really do it. The point is, it's a training program to help people understand how best to support someone.
If I may, Chairman Lee, Representative Carls, there was a session in Grand Forks, I believe it was a 5-day session that offered a level of peer-to-peer support training. And there's another one coming up in Minot, and I'm registered for the one in Minot. It's enough for me to be able to go and help somebody just by talking to them, but to be able to learn more about the process and how it works, and how to protect myself at the same time that I'm helping somebody else is, I think, worthwhile.
So it isn't that we don't know what it is. There need to be some certain educational criteria, I would even pick one, to allow people to be better at listening and responding. As would be true of the coaches who are a part of the game. Because I know some folks that work with AA and recovery alcoholics. So I would think that makes it.
Yes, thank you, Chairman Lee and Carl. You were talking about peer-to-peer, and I find that having experienced this with our son, one of the things that helps is having somebody to talk to that has experienced the same thing. That's one level, you know, they can, I can share with others what we've experienced. But one of the challenges I find is that, okay, how can I send them somewhere for the very specific help they need? And so like I've been in touch with a group called Family Voices. And while they're aware that there are limited options for people with mental illness, for resources and that other than, you know, state hospital and back to community, it would be really nice to have a list of those, both publicly funded and private funded providers that can address very specific mental health diagnoses and those options. What are the options? Because one of the times that we had difficulty is when we had a premature discharge and no place for our son to go. There was no place that would accept him. And the one place that was recommended by his medical provider said they wouldn't accept him. And so it created a crisis bringing him back to the community. So do you see in your organization, your association, the creation of a list of those providers so that someone can just go down that list and say, okay, this provider can work with this situation, this provider can work with this diagnosis, this provider can offer temporary housing, those kinds of things, supervised living arrangement that is available in a community. A long question, but I'm hoping you can shed some light on it.
Representative
Scrog.
Scrog. Chairman Lee, members of the committee. If memory serves, Heartview is working on such a list. I don't know if it's encompassed just for substance abuse disorders or mental health in general. But it would be really good to have such a list. And an example briefly, if I may. I asked the newly elected mayor of Bismarck for a proclamation for September 9th to be Fetal Alcohol Spectrum Disorders Awareness Day. And it was denied because we didn't have a local sponsor, which is fine. But his staff referenced a state organization that supposedly supports fetal alcohol. And we can't really find that state organization. They have a whole list of places that support it, but they're either not answering the phone, they're not returning emails, or their organization is so in turmoil and has had so much staff change that they're not effective yet in supporting it. It's a struggle, but it's such a list such as you described would be, I think, difficult at best to maintain.
Keeping any list updated is really hard.
The list that was referenced listed a gentleman named Bob Broughton who worked for DPI, and he is retired a few years ago. So it's not a current list.
Just to follow up this conversation, I think it's important for everyone to know that probably the best list that's available right now is put out by 211, and any of us can call that, and they have the list of those providers Now, it's a struggle for that entity to keep that up to date, but it requires all of us to provide information, and it requires us to fund it properly. And that's part of the recommendations. But anyway, just an initial thought anyway is 211s, and we should all start using it more. Thank you.
Yes, and they accept calls from every county in the state every year, so we need to step up the state level. Representative Fry, you gonna follow up? I wanted to, I had a feeling Senator Matherin was going to answer the primary question.
We're going down the path that I was.
Okay. Representative McDaniel.
Thank you, Madam Chair. Has your organization been in touch with, I'm sure you have, the county social service workers? Are they referring people back to the peer-to-peer support? Or are you finding any roadblocks with the county social service offices?
Representative McWilliams, Chairman Lee, members of the committee. I'm not aware that we've been in contact with county social workers, social service organizations, not at this point, but that is something we could look into to see how things are represented or being delivered to the consumers.
Thank you.
Any further questions? Representative Schneider.
Thank you, Madam Chairman, and Carl. I just wanted to express my appreciation for this testimony. I think it's powerful and a succinct overview and reminder of directions that we need to go. And then I would like your input on whether or not you see, pathways to implement the changes that you're requesting, or do we have to start over with the $27 million we asked for last legislative session and only got $300 and some thousand? Where do we go? I think you have a real powerful position paper here, but what do you see, or does your organization see as the best route to implement change?
Representative Schneider, Chairman Lee, members of the committee. $300,000 is not even a raindrop in the bucket of what we need to cover the crisis. And the crisis isn't going to be cured in one way. I don't know that it can be cured in 3 bienniums, but we need to start somewhere. And if we could get at this point $27 million, then we have to get less. But I think it would be significant. We would need significantly more than $27 million.
In our interim committee meetings in the last week, which Representative Hogan and I chaired at that time as well, we knew what it was going to take to do what had to be done. And we made a conscious choice, for the benefit of everybody in the room who may not be aware of this, made a conscious choice to put together the bill that said, if we could do everything, this is what it would take, it's $28 million. Knowing in a tight budget year like the last one was, there wasn't going to be any way to get all that money, but we wanted our colleagues in the legislatures know what kind of cost it was going to be in order to provide the kind of services that the people in our state needed. So it isn't entirely fair to say we asked for $28 million and only got $300,000, because believe me, there were lots of us who were disappointed in the funding. But it was a very challenging budget year, and as letting us know, the funds out of which we might pull money pretty much got empty. But we are hoping to be able to improve on that this time, and we need to be cautious about spending as well. But this is extraordinarily important. I'm sure everybody in this room, to a lot of our colleagues as well. I'm confident we're going to keep working on this. We do have some plans in mind. We don't have to plan anymore. You're absolutely right. We've got good stuff here. And we're, in my opinion, really way beyond the shoulder report at this point. The HSRI is really good. And there's a summary of that for everybody that's ready. I'll find that one. And we'll make sure that everybody has it. I know it's been prepared to us. The big book.
Yes, I've been through this book many times since it was
Yes.
published. And the summary is a good place to start.
Yeah.
And then I would look at the recommendations that they list. Sadly, they don't reference specific parts of the rest of the book in the recommendations, so you can go to specific page numbers of what the study references statistics and things like that. But the summary and the key recommendations are a very good point to start with this.
Exactly, so I would encourage everybody to get it.
Just one question. Thank you, Chairman, and Carl. I very much appreciate your testimony and your knowledge on the subject. I'm just wondering, with the coverage now being required for health insurance companies to cover mental illness, if that will have a positive effect on people's ability to pay for services for mental health needs, if that will have a positive effect in helping with funding.
Representative Stroud, Chairman Lee, members of the committee. I want to say yes. I know we in the community were delighted with the July 10th proclamation about ABA services. I would like to say yes, but I would need to look more at the data to be able to confirm that that would be a yes.
Or maybe to see how it actually works.
And
once
maybe
it
see how it actually works, yes. And we do have people on the team that are good at analyzing that kind of information.
Yeah, I would like to have any kind of input you might have on that. Thank you.
I would like to move along, and we're going to shorten our lunch hours, so as not to be too far behind this meeting.
Thank you for your time.
But I appreciate Mr. Young's testimony and always, as always, the participation here, so we look forward to working together on this. Any other interested persons who wish to testify? Good morning. Good morning. In the interest of time, if you are going to be speaking, it would be great if you would pass off the testimony a little bit here, just to get, and then while the next person is wrapping up, and also if you would sign the board. Every minute we see it is sometimes different. Anyway, thank you, Carlotta, and please go ahead when you're ready.
Chairman Lee, members of the committee, my name is Carlotta McCleary. I'm the Executive Director of the North Dakota Federation of Families with Children's Mental Health and the Executive Director for Mental Health America of North Dakota. Today, I am here, Marcia Heddick, who is our president of our Consumer and Family Network, prepared testimony, but unfortunately was not able to attend today, so she's asked me to read in her stead. Chairman Lee and members of the committee, my name is Marcia Heddick. I'm a consumer from Elgin, North Dakota. I am currently the president of the Consumer and Family Network. Today I speak on behalf of the Consumer and Family Network. The CFN's mission is to ensure the mental health system of North Dakota, including community support programs, are consumer and family driven. We will work together to be informed and advocate for our recovery, choices, and possibilities. The CFN has established 4 priorities: funding for peer support, enhancing funding for recovery centers, training law enforcement and hospitals, and establishing a 1915I state plan amendment to Medicaid. The 2018 North Dakota Behavioral Health Systems Study by HSRI states that peer support services are delivered by individuals with personal experience as users of behavioral health services. Peer support services users develop self-advocacy skills and build confidence to pursue their goals through establishing trust and rapport built on shared experiences. Given the growing evidence base for the effectiveness of peer support services, both in terms of quality of life and outcomes for individuals, and in terms of cost savings to counties and states due to the reductions in rates of hospitalization, these efforts have the potential to make significant improvements to the system. The HSRI study further states, despite the limited availability of peer support services, stakeholders who had received peer support services reported that working with a peer support person made them feel more understood. I live in rural North Dakota. We don't have services bigger towns and cities have, but we still need services. The Schulte report said that the use of peers, family support peers, recovery coaches, and other persons with lived experience is an evidence-based practice and a growing national trend with good treatment outcomes. In rural areas with behavioral health professional shortages like North Dakota, using peers and other interested persons like teacher, law enforcement personnel, emergency workers, etc., are instrumental to expanding the workforce. Peer support works, and it is a service that deserves to be supported for communities like mine. But it is not good enough just to create or fund peer support programs. The people who dedicate their time to peer support must be respected as employees. Currently, North Dakota's peer support workforce is being trained to provide services, but there is no plan for jobs to be available to these people once they've completed that training. The HSRI report also states that a significant challenge is to ensure that peers are utilized appropriately and are compensated with a livable wage so that people may be encouraged to pursue a peer support as a career. Current wages are low and many peer support workers are only able to work part-time. We need to change that. Another priority of the CFN is funding and support of the 8 recovery centers. Recovery centers have peers as staff and are primarily contracting with the human service centers to provide services to consumers. The Williston Recovery Center is operated by the Human Service Center. The recovery centers provide job coaching, wellness groups, educational programs, and skill trainings, as well as other volunteer opportunities. Consumers feel that their recovery center gives them a place to be part of a community. As we have said in the HSRI report, recovery centers had their funding cut by 25% last biennium, which made them reduce hours and staffing. There has been a lot of burnout among current staff. We feel that recovery centers could do so much more for the community if we had proper funding. The CFN members have also expressed concern about the lack of awareness of mental health issues among law enforcement and hospital staff. The HSRI report says that we need to train people who work with the public system about mental health and what it is like for people when in crisis. The report says training should inform these stakeholders on the social determinants of health, trauma, and trauma responsive approaches, cultural competence, and rehabilitation and recovery. Trainees could include physical health care providers, teachers and daycare providers, law enforcement and other first responders, criminal justice professionals, including correction staff, social service agency, public health workers, child welfare coordinators, vocational rehabilitation providers, housing authorities, and developers, and others. As you can see, the HSRI thinks we have a lot of work to do, and CFN agrees. We need mental health and mental health crisis training for law enforcement and hospitals. The CFN stands by the Schulte report and HSRI report's conclusion that we need community-based services and funding for those services. We strongly urge the state of North Dakota to establish a 1915I state plan amendment to its Medicaid program. The HSRI report clearly states that a 1915I helps states provide a wide range of home and community-based services as a state plan option. With the 1915I, North Dakota can fund services we need and services that CFN thinks that are crucial for consumers, including peer support. Thank you for your time, and I'd be happy to answer any questions that you have.
Thank you. Any questions, Ms. McCleary? If not, thank you. Okay, any other interested parties who would like to speak? Good morning.
Good morning, or afternoon. I'm gonna start off by apologizing. I'm a registered lobbyist and I don't have my pin on because I didn't plan on
I'm
testifying.
not a police officer, right?
Okay.
Well, you can, just because you and Mr. Young know your legal, I don't really care.
Okay.
Okay.
My name is Melissa Schroeder. I work with Family Voices of North Dakota, and I just kind of wanted to offer some information and possible help to you. I am the North Dakota Parent-to-Parent Director within Family Voices, and it used to be at UND, but has been gifted over to us. And so I just remember Madam Chair you talking about it at UND and Representative Sprout about Family Voices. I'm also the board president for Parent to Parent USA. So there is a national alliance, so to speak, of trained parents, trained family members who do offer this kind of support. And if you want more information on it, I'd be willing to send it to Michael or present.
If you would do that, that would be great.
Okay.
Because we would like them to have your contact information as well.
Okay.
So if you would be willing to put together something and email it to Michael C. Johnson and then
Okay.
don't forget the little initial.
Okay.
And then it'll become a part of our minutes,
Okay.
and we will have access to it.
All right.
So we will look forward to your keeping us in the loop, and
All right.
we will try to do the same for you.
All right. Sounds great.
Question.
Yes, Senator Manning.
Thank you, Madam Chairman. And my question of you is, does Family Voices take positions like on the HSRI study recommendations? And if you do, have you taken a position regarding those recommendations? Are you supportive or neutral or against them? What's your position?
Madam Chair Lee and members of the committee, Senator Mather, I am not in a position to answer those questions, but if you'd like, I can take them back to our director and have her get back to you. Okay.
And we are getting the link for the behavioral health summary, the report summary, so everybody will have that, and there's also a link to the full report. If you really like reading. Because we're going to have those things. Available electronically, we'll have it for you. Anything further? If not, thank you very much. Any other interested parties? Yeah. Second call, third call. Now I'm ready to open the meeting.
Oops, sorry, Tam,
Well,
I'm stepping on your
discussion at this
toes.
point, is there any further information? One thing I was so out is the idea of exploring the idea of a voucher for mental health as we move forward substance abuse. So perhaps we might ask that there be, that's pretty simple, a bill director consider at the meeting. That has- give us a and then we can get a little clock in between and stuff, and get a little more background information. We have, I don't know what the current number of providers is, it's been increasing regularly, which is great. And it's really out there to provide services to both, especially those, I think, that, that are in areas that don't have a legal service center. I keep using Valley City as an example, we don't have to drive the same song.
Thank you, Chairman Lee. I mean, I'm struggling because the HSRI report is rich and the comments this morning were excellent because they're very specific. When we did the shelter report, we got it 6 months earlier so we could digest the specific recommendation. So the timing this interim is really hard for us because how do we know which of these pieces to put in a package? And so I think as a committee, and Senator Lee and I have had this conversation, to figure out how do we use this and make wise recommendations is hard, I think, from the interim. And so I think if you, every member should look at it, and some of it may come through the interim processes, but some of it also may come through individual bills. And hopefully some of it will come from the Department of Human Services. But the realities of it are, we're 6 months behind where we were on Schulte, just so you're aware of
So
that.
you feel good about that.
The fact that when you're feeling overwhelmed, it took us 6 months to get through where we were with Schulte to get to recommendations, and we don't have 6 months to do it. And so I was feeling like how are we ever gonna be able to do it? We're not. And so this will be the roadmap for the next 2 years. And pieces of it will pass, and there may be priorities. You know, I think peer-to-peer came up in both Shelby and HSRI, so it might be one that we wanna look at. And then enhance a voucher program, which has been so successful on the substance abuse side. But it's really gonna be hard to do.
And we want to hear what Ms. Agnes has to say. Senator Mann.
Thank you. Appreciate those comments. I have a little different slant on it. I think the HSRI report is essentially building on our work from the past.
I agree.
So, I think there's considerable that can be done, and the report was asked for by the executive branch of government. And I presume the Department of Human Services will actually put all of it in their budget, or tell us why not. I mean, that's why there's a study done. And I think we ought to ask what the recommendations cost. And we ought to ask the department's plans in light of that recommendation. I think that would be a legitimate thing to do. We spend money on a study, we ought to figure out what we're gonna do with it.
We will be hearing, I believe, about some of that, but Pam Sagas had a bill trial. And this isn't funny, but Chris Jones had surgery yesterday for having mangled a tendon in his right hand. And he was trying to hang, as I understand it, a bike rack in the ceiling of his garage and fell. And he said, but the problem is, I knew that was gonna happen. I said, well, you are going to be the poster child for the falls are bad campaign. So he's all wrapped up, he can't do anything for 8 weeks with his hand, and there's some concern about the feeling returning.